a lot of diabetes and vascular disease.
Gentlemen, shall we? Dr. Antonio is going to ask me why. Shall we start?
Yes.
So that's it, Kevin. Thank you for all. We're presenting this meeting. This was one better. This is one of the Mondays that SBAIT, the Brazilian Trauma Society, is responsible for presenting cases, bringing our personal difficulties in Brazil, a huge country with many different realities. And we are very open to this discussion in this group. We learned so much. And for today, we're going to have Dr. Maria Fernanda Detanico. She is a trauma surgeon in the Hospital Cristo Redentor in Porto Alegre, the southest state in Brazil. And they have a huge experience in trauma. I'm certain she's going to present a very interesting case to us. Well, I would ask anyone to have any question to put in our chat. I'll be looking at it. And if you want to participate as a panelist, please have a message Kevin that he is going to put you there. Thank you for all. Maria Fernanda, can you start?
For sure. Thank you for the invitation. Good afternoon to everybody. I hope somebody already said, I hope everybody have a good St. Patrick's Day today and have some toast. So I have to say that this specifically patient was a long time ago. It was 7 years ago that I've attended this patient, and I can tell you that it's still in my mind if there is anything that we could do different or better or anything. This patient specifically is still 7 years later, is still in my mind. So let's start. Deixa eu ver onde é que eu tô. Aqui e aqui. So, tá compartilhada, ok. So this is everybody seeing
It's still in. It's not in the. Não está no modo de apresentação.
Não tá. Ué.
Não.
Pra
Você
mim,
selecionou
tá
a tela toda? Have you tried to select?
Não, tá aqui, tá pausado. Peraí. Deixa eu ver. Ué. Retomar.
No problem. You just try again using entire screen. You have to click on entire screen.
No, but it is for me. It's this way. So I come back. So let's start it over again. And not this one. This one.
Right, entire screen and click there.
Yeah.
Then everything that appears to you will appear for us too.
Compartilhar. It should be this one.
Yes.
So now?
There.
Okay,
Yes.
perfect. So this patient was a female, 20 years, a car accident. She was rolled over. That's why like a rolling stone, without a seatbelt inside the car, high velocity. The trauma was around 11 p.m. and she was first attended in a rural hospital and then transferred to our facility. She arrived on December 22, more or less at 3:30 a.m. here. So the first exam was airway okay, cervical immobilized, pulmonary exam okay, bilateral brief sounds, respiratory rate in 20, heart rate in 110, BP 150, pelvis okay. It was in the medical chart. Diffuse abdominal tenderness and no urine output. Glasgow 14, pupils okay, no neurologic deficit, no other signs, no other fractures, ample okay. And then the first management was whole body, CT whole body plus labs. So I was just to start a little bit here because I can have some spoiler after. I arrived in the next 8 a.m. started my shift, and then my colleague just passed me. No, we have one female patient car accident. She's okay, maybe a spleen, a little liquid fluid in the abdomen, nothing more. She's stable. But I asked a cystogram because she has no urine output at all. I changed the Foley catheter 3 times and it's not working. So I think that she has a bladder rupture. And I said, okay, let's go. Let's see the patient. So I arrived at 8 a.m., as I said. So we reviewed the patient and the CT. She was still stable, just a little bit, the heart rate was a little bit high. No urine, it was more than 6-7 hours inside the hospital. Still a little abdominal tenderness. It was asked 2 units of blood and morphine. And this is exactly what the nurse, at the AD, at the emergency department, she was still in the emergency department. She said to me, we changed the Foley catheter 3 times and there is no urine. There is not a lot of fluid. We could see by the CT, something is wrong. And then that's when my nervous started. I will change because I will share another one because I want everybody to see the CT.
EV,
and then we go,
contrast. Did you have
the first,
EV?
It's one of the problems that I have here that I try and I try and I try. The first CT with all this trauma, without, like, she was without the seatbelt, the car just roll over. The information that we had that it was a huge accident. The first CT was without contrast.
I understand.
And then they
understood. Okay.
And then they made another CT. And then they made another one. And then this one, unhappily, I think
Would you like Dr. Untrach perhaps comment on Dr. Untrach could comment on this mechanism and what could be happening without urine output?
Yeah, so it very, very concerning. Initially, you see the heart rate of 110, normal blood pressure. You say, well, okay, she's tachycardic. That's a bad sign. But she had the stress test of spending the night in the ER with the vital signs remaining stable. So that's a plus. But I gather she was the sole occupant and the driver because she didn't mention other drivers. And it's very, very concerning mechanism, especially the no seatbelt. So in addition to any intra-abdominal trauma, you really worry about cervical trauma that maybe hasn't manifested yet, or an unstable cervical fracture that needs to be stabilized to prevent a spinal, irreversible spinal injury. So all those things I would worry about, although you're just coming on service at 8 o'clock. So any delay is not really your responsibility, but you need to, just taking responsibility for the patient, you need to see all the studies that were done and rule out spinal injury, ongoing bleeding in the abdomen, and certainly bladder rupture is one possibility. I would have done an EFAST exam right away, and given that the CT was already done, I would look at that, still do an EFAST exam because of the time lapse since then. But I agree with Dr. Fernanda that there are a lot of things to be concerned about. Need to really get a handle on the patient, her injuries, and rule out certain potentially serious injuries.
Do you guys have the same problem? People call kind of this mechanism of trauma. People offer you a non-contrast, non-enhanced contrast for CAT scans. It's a bit common when you have a medical doctor take care of the OR, the ER, sorry.
and it's something that we're fighting. We much better now, but it's still fighting. It's still fighting. And this is I would change from I'm signing with two persons in the Zoom exactly because I want you to see the CT. And I will share another one. And I was really having problem in my computer. So thank you. Somebody also is having the same problem.
Fernanda, you can exit the.
I think I will go.
You exit the Zoom and try to share your.
So,
Yes, it's okay.
So,
That
okay.
is that's okay. Good. This is the
So,
second one. Yeah.
Yeah. To be honest, this is gonna be the third one because second
Yeah.
one. We did the second one, and this is something that we have a residence program here. And I'm pretty sure that it was the resident who saw the first one with the second one, maybe with the contrast and with the eyes, not with the surgeon. Because this is, as I told you, I arrived at 8 a.m. and I saw the first with contrast. And I was really, really upset with the things that I saw. And I really, like I told you, it's 7 years ago, it's still in my mind. So this is her CT. In the thorax, nothing, just a little of pleural effusion, nothing. So you're gonna have to see like free fluid, and a spleen lesion here, small, also here in the liver.
Yeah,
and
the arterial phase.
You're gonna see this way. As you can see, you have no kidney at all. So we have both renal.
Bilateral.
Yeah.
Exactly.
Boy.
This is what we had. And this is how I arrived in the morning, and this is what I got.
How long from the injury? How many time? How many hours?
9 hours. 9 hours, maybe. It was more or less 11 p.m. And then as I told you, I arrived at 8 a.m. and then I saw the first one, and I saw that the kidney was completely no blood at all. And then we had this, and this is an aorto, it's aortography. So that's like we decided to see better if there is. And so even to see the other arteries, if there is anything, because of the magnitude of the trauma, maybe also we can have like a mesenteric injury or other. So this was the case.
No peritonitis, no free fluid.
No free fluid, and
small
amount next to the liver, because she has a lesion here, and also she has a lesion on the spleen.
Perhaps grade 2, grade 3 liver injury, grade 3.
I think grade 3 both. Yeah. Grade 3, 2 to 3. Yeah.
So it's open to discussion. What would you do? Let's start with
this time. Just to be sure, at this time again, it was 8 to 10 p.m. She has a little abdominal tenderness, like no needs for a lot of painkillers. She just received like 3 milligrams of morphine, so not a huge thing.
I think Dr. Kassim raised his hand. Dr. Kassim would like to comment. Dr. Horman.
Well,
can start, Dr. Kassim. Yeah.
Can you hear me? Can you hear me?
Yes.
Perfectly.
Yes.
Perfectly.
Okay. So the hour between 3 and the next shift, it is called the devil's hour. The reason being, it is in the middle of the night. You know, most people are sleeping and you are the only one, you are up. And if you are not a very knowledgeable physician, you tend to kind of underperform, and you wait for the morning break to happen so that you can pass this on to somebody else. And two things impressed me on this case. The patient did have symptoms. She had abdominal tenderness. And she was obviously complaining of some abdominal pain, even though her vital signs were not that profound. She had a slight tachycardia with abdominal tenderness. And then you try to put Foley catheter ×3, and there is no urine. That is called anuria. Anuria is a very, very significant finding, and don't blame it on the Foley catheter. You know, you need to start thinking about the possibility why this patient is anuric. And then on top of that, you know, she has a CT scan, and actually she's lucky not to have the contrast injected right from the beginning, because that will cause additional damage to a kidney that is already injured. So you have many things happening to this young lady during the devil's hour, and very poorly managed, I would say. But when Dr. Fernando arrives and she notices there's something seriously wrong here, and she takes the bull by the horn, and she finds out that the patient doesn't have functioning kidneys on both sides, which is horrible when you think about it.
Right.
And so if it was me in Dr. Fernando's situation, I think I would be mortified, and I would definitely go into action to see if I can salvage this patient, because she could possibly die.
And this is what I did when I saw the CT. I called the vascular surgeon, I called to the endovascular surgeon, I called even a friend that works with transplantation to see if there is anything, because the problem was 9 hours later. I was seeing this patient for the first time 9 hours later of the trauma. So I talked to them if there is anything that I could do at that moment that could save the kidneys, or at least one. And it was my purpose, and I can't. This because I say that it's a patient that is still with me even 7 years later, because it was 20 years old, a young girl with it's Christmas time, so it was really, really hard to look to her and say you lost her both kidneys, to look to her mother and say she lost her both kidneys. She had two, now she had none. This is what, so I tried at this first, and both of them, they said because of the time, it was already 9 hours, it was too long. Any type of revascularization that we're gonna do now, we're gonna kill. We're going to kill.
Maria Fernanda, can you comment on this question on the chat? Stephen Epstein asked if she needed a cystogram. Would you do a cystogram?
No, with this one, no. It was not my it was not my choice. It was my colleague who passed the case, like it was simple, nothing, but she's not urine. They changed the Foley catheter. She put the blame on the Foley catheter, and but exactly. He asked it, but he changed it 3 times. She had the CT. That was the point. She had already the CT. She could have also a bladder because of the trauma, but she had no urine output because of this. Both kidneys are completely with no blood.
You found a reason for the anuria.
Yeah.
I understood Dr. Epstein's question. It's very interesting because you cannot exclude a bladder injury without a cystogram. But Fernanda seems to be satisfied with the CAT scan findings. Well, Dr. Ontrach.
I will go a little bit down, so we can both see the bladder is still a little. So we have here like free fluid, and
it's difficult. Without contrast, it's difficult. So, but it's a very good question. Dr. Untrach, what do you do? Do you have any case like this before, like both kidneys? Can you comment on the treatment if you have one kidney thrombosis?
Right, yes, I can't recall both kidneys not functioning. You know, in my day, we initially we weren't using, you know, CAT scan was not available for the abdomen. It was only available for head CT, and that took 45 minutes, and you did this, that. So we would do things like in the trauma bay, a one-shot IVP to see how many kidneys were functioning, one or both. You know, that was very important to know ahead of time. You would have gotten this answer right away. And if there was no urine output, we would have done that. And if the kidneys were functioning, then we would have done a little
IV
vesiculogram,
contrast,
vesicular, if there was rupture, or sometime, or in fact, for blunt trauma, we would have done a peritoneal lavage, and on putting the catheter into the peritoneum before instilling any saline, we would have aspirated clear fluid that looked like urine, you know, and we would have had the diagnosis. But we would have made the diagnosis early of anephria and or no renal function, and I think that, you know, that was the ball dropped overnight. It's understandable. That's happened, I'm sure, every place in the world. Every top-notch hospital has had a case like this where the diagnosis has been missed. But, you know, anuria for you know, for more than 20 or 30 minutes, you know, should have been a concern, not to leave till the morning change of shift, but you know, should have been addressed earlier on for the reason that Dr. Fernanda mentioned, that you know, you burn a bridge if you wait too long. So.
And what would you, for this patient per se, would you operate a kind of like this? Do you do a nephrectomy? You leave the kidney there? What would you do your idea? Because he has a liver and a spleen injury together. We have to save the patient. There are other injuries too. What do you do?
Yeah, I would do what Dr. Fernanda did, because, you know, just looking at the CT scan, I didn't see any extravasation. Both renal arteries are pacified. So where is what's the etiology? Is it distal? Is it distal thrombosis?
No,
and the other injuries, the splenic and liver injuries, don't need a laparotomy by themselves. They've done okay for 8 hours. But I'd be interested in what Dr. Hockman and Dr. Frisbee think about this, or anyone else that can comment. And I'm sure, you know, even at Tufts, you know, you've seen cases like this where anuria has been missed for too long. You know, the ball's been dropped because of timing, whatever.
Would you try? Have you any?
Sorry, Pajera. Just here was the stop in the left.
Yeah.
And here, no, here. Sorry, here we have the stop in the left. We have some polar, and it was a little bit longer, the right one, but it was already not so.
Yeah, I would have
called both polars. Yeah, but
I would have called the interventionist to see if they can open those up. That'd be the quickest way, rather than operating. It'll take a lot longer. It may not be successful, but I'd be interested in what the others, what our other colleagues have to say about this. But I would start with the interventionist and look at the gallbladder there. Is that a porcelain gallbladder? What is that?
Yeah,
no, it was the first. This was a arthrography. She had already a CT before, but we could not see the renal, the arteries so well. That's why we asked another one. So this is the third one, CT. Yes.
Well, let's ask Dr. Hoffman.
I don't have too much to add to this case, more than what Dr. Kasim already mentioned. Patients who don't have urine, that's a priority. My first thought was also a bladder rupture, and when the bladder, when the CAT scan, I was thinking, and if there is no urine, the patient needs to have a CT cysto. Having said that, probably we get a complete CT before, and this should have been detected. I was thinking the other possibility when all this being discussed is bilateral transection of the um,
Renal
renal
artery.
arteries, but
Yeah.
it's extremely rare. I have seen unilateral ones, but bilaterals with no other injuries is usually associated with a big deceleration injury. This patient was not wearing the seat belt. So it will be low. It's possible it will be low, but the bottom line, as Dr. Kasim already said, this patient needs to be investigated immediately, cannot wait till the morning. Why is not making urine? The most common, most benign thing is a ruptured bladder, but this is not something that I will leave for the morning. 9 hours later, you lost your window of opportunity. Nothing else can be done, unfortunately.
Do you have,
In
do
the
you have
past,
a, do you have, sorry by interrupting you, but you have
yeah,
a, how many hours would you try it? Kind of, you know,
uh,
revascularization.
usually after 4 hours, there is no chance to recover the kidney. Uh, but again, it's very unusual. You will be worrying a patient like Dr. Unchak was saying. In the past, we used to do a pyelogram in the trauma bay in case that we needed to go to the operating room and remove one of the kidneys, make sure that the other kidney was there. Now we stopped doing that, but this is something that um, is is so dramatic with something like this. You need to really have very high. You need to really act quickly. The question is what to do with the kidneys. In the past, the traditional thing was to remove the kidney because it was being marginally perfused and it would produce too much. The renin, angiotensin, aldosterone system will be elevated and it will cause essential hypertension. Now it's just to wait and see. The left kidney has a little bit chance of if the transection was a little bit more closer to the aorta, it's a little bit distal because you get some supply from the adrenal, the left adrenal. But in this case, I don't know, there is some excretion of material, but probably not enough to maintain kidney function, but maybe enough to give you hypertension that the kidney will need to be resected at a later time. But at this time, I wouldn't do anything else. I would have to delineate the splenic and the liver injury and see if the splenic injury needs embolization and go from there. The window of opportunity has been lost, unfortunately. Sorry.
Any other
Uh,
idea?
Pajera,
the-
just to also to answer, I asked it because I asked one of our colleagues that it works with kidney transplantation, and he said to me, no more than 3 hours. They say like it's warm ischemia could not be no more than 3 hours. So yeah. So she was
Dr. Kasim,
really.
Dr. Kasim, would you like to say something?
Yes, I do.
So please.
In a case like this, where there is a blunt trauma and with a possibility of a liver injury, splenic injury with normal blood pressure with a little bit of tachycardia, but the main problem is anuria. Anuria is very serious in a 20-year-old, and you cannot just write it off as something that you're going to wait and see what happens and all that. In my opinion, a patient like this could easily have a bilateral compartment syndrome of the kidney. She may have injured some vessels in the kidney, and both kidneys are encased in a significant amount of blood, and it is not perfusing. Who knows? It is a possibility. We have seen a case of a bilateral compartment syndrome of the kidney many years ago in a presentation at this particular meeting. And so I think I would take the patient to the operating room for exploration, and I would not wait for the interventionalist to come over and do some fiddling in there. Because it is such a serious injury, in fact, it is life-threatening. I would be very surprised if this patient doesn't make it.
Any other comments? Maria Fernanda, can you proceed?
Yes, just let me go for my presentation. That is wait. So
Perhaps you could comment the treatment for unilateral renal arterial thrombosis in your hospital. What do you recommend?
normally we go for the patient. That's the point. If we don't operate as routine, we're just gonna see how the patient is going. We go for this. We wait and see, basically.
And
So,
eventually, let me ask you a question, because sometimes I kind of had this questioning in current situations. If you are to operate the patient, if you do not need to operate the patient, you leave the ring, you leave the kidney there. You leave the kidney there. Okay, it's okay. But eventually you will have to operate the spleen and take the spleen out. Would you operate the kidney also, or you would leave it there?
It was like really what I do. I normally, if I have to go through the abdomen, I take the kidney.
Okay.
I will not, as I said, like as the patient is going well with no other problems, I will left the kidney there. I will not touch. But if it's not, even like we had a patient 3 years ago that the major sign, he had also a ischemic kidney, but the major sign is that he was not accepting diet. We be putting the abdomen was huge ileus the whole time. It was not passing gas, not accepting diet at all. So it's still with the inflammatory markers really high, and nothing. So the decision, it was the only cause. There is no other. So we took off the kidney, and after that it was okay. So we go for that. But if we had another, here we kind of have like 2 to 3 cases every year. So and as I do the routine of the hospital, so I see all the patients, I know all the, and I have a good memory. I know all the cases, and also I have this, so I can
They're not so frequent in this patient. Eventually, you see you in the clinics afterwards to manage the arterial pressure. Yeah, that's the same. That's the same. We eventually, if you go if we need to operate the patient, we tend to do the nephrectomy, but otherwise we just just observe. Dr. Untrach, do you think the same?
Yes, you would follow the patient, and if they have renovascular hypertension, you're sort of bound to do the nephrectomy, but otherwise, I would do it as Dr. Fernanda mentioned.
We had, I remember 2 situations here in this hospital, Santa Casa, with bilateral renal artery thrombosis. One of them, we did nothing, but the guy is really, really severe. He had got a open abdomen and damage control, and after all, he passed away, unfortunately, perhaps 3 weeks after. And the last operation, he had some, contamination in the retroperitoneum. That's why we think extracting, if you go to operate the guy, it's good to extract the kidney, because in this particular case, of course, just one case, you just can't make it a rule, but we got some kind of infection in this necrosis of the kidney parenchyma. And the second one, we tried to revascular, go to the OR with the vascular surgeons, exactly as Dr. Hoffman said, or Dr. Kasim said, go to the OR, try to explore and revasc the kidney. And we tried, and unfortunately, it did not work, because like 9-10 hours after. So that's our experiences, where it's good, this kind of meetings, because we kind of learn from each other, because they're so rare, these cases. Let's go on.
So I will change from, let me see, let me just change here.
And if anyone in the audience, and we are in the chat, please write your experience with this kind of injuries. Do you have any case you could revascularize? Because it's very hard to hurt a case that it really, reperfused on time.
So,
It's happening again, Maria Fernanda. It's not in the
Opa.
presentation mode. Yeah.
Então, vamos voltar. Opa. Bueno. Vamos compartilhar esse aqui. Done?
Yes, much better.
Okay. So, as I said, like the trauma was hepatic with grade 3, spleen grade 3, and kidney bilateral thrombosis with a small polar artery at the left. So the decision at this time, well, no surgical treatment at first, and we did the CT as you said, as we saw, ICU admission, Chile catheter already for hemodialysis, re-examination through the time. But things changed through the day. At 4 p.m., sorry. The abdominal pain was increasing, so she was needing also high doses of morphine and also starting fentanyl. The abdomen was with diffuse peritonism. And this was their labs at the time. It was after 2 units of blood, HB of hemoglobin of 9, platelets 100,000, and the creatinine was already 3.5. But as the physical exam completely changed, and as I told you, I was who saw her at 8, and then it was again me who examined the patient at the time. It was a completely different physical examination. That's why the decision for the laparotomy. In my mind, also what could happen is if with all of these lesions, like all the solid organs, all the 4 solid organs, they had some kind of lesion, it was not improbable that we're going to have also some other viscous and hollow viscous injury also. That's what I was planning. I can tell you that in my mind at the time, it was like, we're going to open and see. If there is any cause for this abdominal pain, I will not touch the kidney. If it's not, I will took off the right kidney. I will take the right one because it was in the exam, it was the more ischemic one. And as a cause for this abdominal pain and all the situation. It was in my mind. So
You're planning.
Yeah. This was what I planned and what I did. The splenectomy, I can tell you that I did because, taking off confusion stuff. And as I did the right kidney, we started to bleed the liver. We just put the doya and then, start to bleed and all the rest. So just pack it a little, just the liver. And the spleen was, by the way that I was there, by the way, of all this trauma, by the way, I was with this confusion, too much lesion. So I decided to take at least one confusion factor of all of this. So any question?
You can go ahead. Let's go to the end.
So in the 24, she was still a little bit unstable, using noradrenaline. The HB was stable. They started antibiotics. In the 25, still but it decreased in the dose of noradrenaline. It's still the protein C was really high, still 380. So my colleague decided to take off the other because she was still not in an inflammatory response, and we're not so sure if it was. And the problem is that, okay, I will not go, I will be able to go in 2 to 3 days because of all these laparotomies that she's having. This was the question. So, and we discussed in a group and he said, no, I think you are there because of that's what we said. I think we should remove because we are not so sure that in 5 days, if she's not getting better, we're going to be able to get into the abdomen again. In 24 hours, she was just in no more vasopressors. the protein C already stepped down. She was still in mechanical ventilation, but no other problems. And until January 3, she was in the ICU, hemodialysis, with no sign of infection or complication. I don't know if anybody wants to do any questions. She went to the enfermaria, Parreira.
Ward.
The
Library.
ward, yeah, the ward, to the clinical ward, like to our care, but she was stable. And here in our hospital, we don't have like the traditional, the conventional dialysis. So she needs to go to another hospital to do the hemodialysis. And then in 10/1, she was stable. We didn't see her in the morning, but the plannings to discharge was Monday. She was really good. She was eating nothing, like everything was just like, we take the at that moment to her to make the dialysis, to everything was planned with the social service, everybody, because it's another city, to be everything like, we're not gonna discharge the patient on a Friday. And then she went to the dialysis and massive pulmonary. She arrived at in the hospital in cardiac arrest.
This is so sad, Maria Fernanda.
Yeah.
This is so sad.
Yeah, she survived.
I was asking you
was,
so many years ago, perhaps for transplantation. That's the point here. Nah? Perhaps you say, well, if she lost 2 kidneys, well, but she's young, can transplant, no associated injury, no associated diseases, is a good patient for transplantation.
Well, we already like, this is also, we stay with the patient, like trying already to see how we're gonna manage the dialysis, because she was not living in the capital, it was another city. So to be like, it really like the pieces being matched for her to go, everything planned. She was in heparin, she was here. I even, when they told me, like, I went direct to the medical chart and to see, I don't tell me that she was not in heparin. I'm gonna be like really, really upset. But she was, it was like, she could not use enoxaparin or any other because of no.
I believe every one of us have seen such a case. On heparin and massive pulmonary embolism.
Yeah.
Well, it's open for discussion. Let's see, we have 10 minutes more. Let's ask our panelists. Start with Dr. Horman.
Just one small thing also, Parreira.
Yes, please.
And we said to the intensivists, the doctors, the ICU doctors, that we need to also use corticoid, because probably with all of this trauma, the adrenal also was not functioning. So we are also using, because she was needing a little, the point is that she was in a high dose of noradrenaline, and it was not matching. So we also talk with them about adrenal insufficiency. About this, yeah. We thought about everything at the time. I can, at least in my mind, I can tell you, but.
Yeah, I'm so sorry for that.
Yeah.
Dr. Horman, anything? Would you?
No, I don't have anything to add. Very sad case. It's like she was receiving anticoagulation, and sometimes this happen. We have a patient recently, the same thing happened. Kind of getting ready for discharge, and suddenly was found dead in the bathroom, and the autopsy showed massive saddle emboli. So, and he was also receiving the anticoagulation and everything, and so these things happen.
Thank you.
May I say something?
Yeah, of course, Dr. Frisbee.
In my old age, I'm getting mellow. Usually, when this all began, there's no surgeon in the ER sitting there waiting like you're a resident, waiting for somebody to come in like I did. But the point is, they're medical people. They don't share the same paranoia about things that a surgeon does. Paranoia comes very, very easily to us. We're scared of everything, thank God. So, you know, these things, as Dr. Hoyman said, and Dr. Pereira, they do happen. There's, you know, you just have to try and put the toothpaste back in the tube if you can. Sometimes it works, and sometimes everything you do is to no avail. But you did a great job on a terrible case. You did a really good job.
Thank you, Dr. Frisbee. Dr. Kassim?
It's a sad case. I was
Yeah.
hoping that she makes it. And sometimes our fate doesn't allow us to live longer. She's only 20 years old. And she went through a horrendous trauma. And things could have done, they could have done something different earlier on when she arrived at 3 in the morning. But still, you know, the doctors worked hard and keep her alive. And then suddenly this happened. I had a case like this when I was doing cardiac surgery. I operated on a patient with triple bypass, and I signed off, sent him home, and he went to the bathroom, and he collapsed and died with massive pulmonary embolism. It was the saddest day of my life that day. This is tragic for a 20-year-old to pass away like this, and it is pretty tragic for Dr. Fernanda and all her colleagues to see this. This is terrible. So sorry.
Thank you. Somebody asked about a lawsuit. It was, I'm pretty sure, as I told you, I arrived in the hospital and I talked to the family. The mother was here, and I tried to be as open as we can be, because sometimes we cannot also take off the faith in something that is gonna work, not for this case, but sometimes like we need to be really realistic about the condition of the patient and what's gonna happen. But I talk to the family. As I said, also, I do the routine in my hospital, so I see the patients every day. If they have the patient, if they have the family, when they are there, we talk to the family. We are open. If they want to talk to me, I'm gonna, because I am the medical resident supervisor. I'll be open. I try to be as much as open and write in the charter of the patient also, that I talk to the family, I explain the risks and everything. But for now, for so long, with the family, everything was okay.
Okay, I think our final panelist is Dr. Untrach. Would you like to comment? Anything else, Dr. Untrach?
Right. I would only add that, you know, it's a message to all people getting behind the wheel that had she been wearing a seatbelt, likely the car would have still turned over, but the outcome likely would have been different. You know, she may not have needed a laparotomy. The kidneys, the renal arteries likely would not have thrombosed because she wouldn't have been tumbling. And so, you know, that's, you know, and you can certainly raise a point to the doctors that didn't diagnose the anuria, the cause of the anuria soon enough, but there's also, you know, responsibility on all sides, lessons for everyone to learn. About the heparin, was she on heparin when the day that she died with the massive pulmonary embolus? She was still getting heparin. So then, then the issue is, well, you know, what, and there are no protocols that say in this case, maybe a, you know, an IBC filter would have been, you know, in retrospect, certainly, you know, it's a point to raise. But and then also, I wonder what her injury severity score would have been coming in, and what her expected mortality was. I think it was probably rather high, right? The injury severity with the, you know, the ruptured liver, ruptured spleen, both kidneys lost. You know, that's a pretty high level of injury. So the expected mortality would have been, I don't know what it was, if you know, Dr. Fernanda.
Let me ask you a question. Let me ask you a question for you too, Dr. Utrash, Dr. Fernanda, this is a case that where you start to think about routine US Doppler US ultrasound for searching, let's say, deep venous thrombosis that are not apparent. It's occult deep venous thrombosis. So there are people with if you have high risk for DVP, you have some kind of ultrasound, routine ultrasound in ICUs. Do you think it's possible, Dr. Trash, to do that in your patients?
We can do at the bedside, look for deep vein thrombosis in the popliteals, but a lot of the thrombi are in the pelvic veins. So, but a lot of trauma protocols, they do these studies. They have the vascular sonographers look for evidence of DVT, and I don't know what the current protocols are. Maybe Dr. Hockman would know better. The case like this, if you add up all of her injuries, the injury severity score, and the already has thrombosis of the two renal arteries. Is there anything in the literature that suggests that maybe a patient like this should have an IVC filter for safety?
Exactly.
And I'm sure the next time a young woman like this comes into Dr. Fernanda's service, she's going to put in an IVC filter. You can't go wrong. The deaths that you don't see, no one can raise an issue. It's this case, that would certainly remain with you for when the next one comes in like this. But are there any protocols, Dr. Hockman? I'm guessing you would say no, because you didn't raise any issues here. Everything seemed to have been done properly with regard to DVT prophylaxis here.
Yeah, no, we don't do prophylactic filters, and the DVT prophylaxis sometimes fails. So really, it's not too much that you can do in these type of cases, unfortunately.
Yeah, had she survived this episode, then you would have put a filter in, right? That would have been
yeah, well, we probably anticoagulate. She wasn't fully anticoagulated. Imagine she was receiving DVT prophylaxis with heparin. Lovenox is better, but she has no kidneys, so you cannot use Lovenox. So you have to use the regular heparin. We try to adjust this by weight. And now, if the patient is in the ICU, we follow factor 10A active to make sure that they receive adequate. Some patients have resistance to the heparin for whatever reason. Either they have low antithrombin 3 levels or have low albumin. And those patients, we just follow that way. But in this young patient who was healthy before all this started, we probably wouldn't even do that. So this is very, very sad, but I think that unfortunately, I don't think that anything. I always also say, do not legislate based on one patient. So when we have such case like this, we tend to overreact and start doing more things that can potentially be dangerous to other patients because we are worried about this unusual case. Based on everything we heard here, everything was done by the book. So I really don't have anything that I can add. Sorry.
Yeah, and one other point. So even if the anuria is getting to Dr. Kobe's question about liability, even if the anuria had been diagnosed at 3:30 a.m. when she came in and attempted to reverse, likely wouldn't have changed the outcome, right? I mean, the thrombosis wouldn't have prevented a massive pulmonary embolus, would it?
Well, we have 2 minutes more. Dr. Fernanda, could
you... Dr. Untrack. Dr. Untrack, I know, you know this. Trauma causes hypercoagulability, right? Even with heparin, sometimes heparin is not effective in preventing hypercoagulability. So if you'd have treated this patient at 3 a.m. and she got away scot-free, I think she would have been home.
And I home, yeah.
Well,
Perhaps.
Difficult answer. Oh, Fernanda, 2 minutes for you. Let's finish the case. Please do your comments, your final comments. And first of all, thank you very much for presenting the case, sharing with us this experience. I'm certain I'm learning a lot from this case from your hospital, and this is not different. Thank you very much for that.
I appreciate the opportunity. As I said, I would not like to put anything on the title, because then just to, as I told you, just to be a surprise. And at least I just have this case, this type of patient in my 20 years. I hope that I don't have another one with the bilateral kidney thrombosis. Probably I will have, I know it's probability it's gonna happen again. But thank you for the comments also, and also the opportunity to share and to discuss. It's always good. Thank you, Pajera. Thank you, everybody.
Oh, thank
And
you.
also, I'd like again to say thank you for the opportunity. The last year I was here talking about a really sad moment in my country, in my state, that it was South Brazil, Porto Alegre. My state was underwater, and I really appreciate all the support that PTS gave to us, and all the, not only PTS, SBAIT, but everybody who gave to us was really important. Thank you, everybody.
You're welcome.
You're
Thank
welcome.
you very much for that. Thank you all for participating, and our especially our panelists. Thank you very much. See you next
Thank you,
Monday.
Thank you, Dr. Pereira.
Thank you.
See you.